Hello and welcome to the Spine and Nerve Podcast. My name is Dr. Brian Joves.
And my name is Dr. Nicolas Karvelas.
And we're going to continue our discussion on the chronification of pain. Please refer back to the past two episodes where we kind of went into some of the science at first and then talked a little bit about that chronification in thinking about something like peripheral nerve stimulation for chronic axial low back pain. But now we wanted to kind of go into a little clinical scenario of a patient that actually is, relatively recently new to our practice, joined our practice or presented to our practice about 6 months ago. And I think it gives a nice illustration of the chronification of pain, kind of some of this central and peripheral sensitization process, and kind of how that affects the overall care of patients living with these processes. Does that sound okay, Dr. K?
Yes.
Awesome. So he's a 50-something-year-old gentleman who has a diagnosis of chronic idiopathic pancreatitis. And so the reason why that's significant is that he's been dealing with chronic abdominal pain for 20 years at this point. Yeah, he's been on very high dose opiates and really was getting by, but with the help of a lot of medication and obviously the help of a lot of medical professionals. And he has a very supporting family and support system around him that had allowed him to stay relatively functional for quite some time. And then he presented to our clinic because he actually had an acute episode of back pain. And so one of the things that we've talked about is how common back pain is, right? And, I think there are studies that would say that it's the most common reason why people present to primary care offices, as well as, an overall incidence of, just about everybody has acute flare back pain in a given period of time. And so, not a very uncommon thing, but for somebody such as him who has been in pain for so long, who has been on high-dose opiate therapy for such a long time, I think it became a much more challenging process. So I wanted to give the floor to Dr. K. Maybe you can kind of walk us through why that became such a challenging thing for him.
Yeah, and we'll do that. And I just want to, Dr. Joves brought up a great case example there. But yesterday I just spent after clinic a patient with a flare-up of symptoms. Spent a long time on the phone with them and their family for kind of a similar situation where they just had very long-term pain, very long-term use of opioids, and then something pops up and it becomes incredibly difficult to treat. And these type of patients are very challenging, and we'll get into the reason why right now. So, like we've talked about before, when we do have the setting of long-term significant chronic pain, we have multiple processes. It's obviously incredibly complex, which you brought up before. We brought up the fact, that it's not just the central and peripheral sensitization, which I'll go into more detail in a moment, but there's other multiple significant factors, genetics, epigenetics. I think that's something that we're learning more and more about, is not just what we're born with, but then the environment that we grow up in and how that actually can change cytokine levels, pro or anti-inflammatory cytokine levels. It's fairly incredible how much all of these things ultimately matter. The level of stress that we have, growing up and through different traumas. So I say all that to bring light to it, but also to emphasize the complexity of why we, in certain situations, we have more chronic, severe, refractory pain. And of course, there's the underlying disease process or injury, which the severity of that obviously and how difficult that is to treat obviously comes into play, and we've talked about in the past. Now, if, for example, if someone has painful peripheral neuropathy, that neuropathic pain is one of the more difficult things to treat. So like I said, all those things ultimately end up contributing significantly. We talked about peripheral and central sensitization. Part of the reason that we emphasize that is, number one, it's very important, but I think also of all those different things, uh, we're starting to understand it, and of course we have a ways to go as well, and we'll always continue to try to optimize that understanding. But we're starting to gain a fairly good understanding of what's going on with central and peripheral sensitization, uh, and like we talked about in the past. With peripheral and central sensitization, the main end result is that we have a significant uh, imbalance, so a compromise to that balance between the pain signals being sent up to the brain and the descending modulation or inhibition of those pain signals. As many things in life and many disease processes, it's all about restoring that homeostasis and that balance. So taking peripheral sensitization first, some of the key things that are happening in peripheral sensitization is after that injury, disease process, inflammation, the peripheral nerves become sensitized. And what does that really mean? Well, there's both structural as well as functional changes that occur. And in terms of the functional changes that occur, this means that the nerves and specifically the receptors on the nerves. So we're talking about the receptors that are responding to mechanical stimuli, chemical stimuli, thermal stimuli. Those receptors that usually would respond to specific stimulation. So, as an example, I think I used this one in the past, the TRPV receptor responding to higher thermal stimuli, its receptor field expands. And so this happens with when the nerve is sensitized. This happens obviously with multiple receptors, whether it's mechanical, chemical, or thermal. The receptor field expands. So if you take, for example, a painful, a nociceptive mechanical a receptor that usually would only respond to significant force or a crush injury, telling you, hey, move your arm or move your leg, we're in pain here, there's a problem. So that receptor, once it's sensitized, now is not just responding to a significant force, but it starts to respond to less significant forces, and eventually, in its extreme state, even light touch. And as we've talked about before, that's where we start to get to allodynia. So that's more of the functional changes of the receptors. The structural changes of the receptors we've talked about, there being an upregulation in the number of certain receptors after these injuries. So we talked about certain voltage-gated sodium channels that will change in their number, and obviously that's going to change the intensity and the severity and the frequency of the pain signals that are being sent. So one other thing I'll mention about peripheral sensitization is obviously that peripheral nerve. It's a cell body living in the dorsal root ganglion. The dorsal root ganglion, we are continuing to understand how critical that is in the development and the persistence of chronic pain processes, including change in protein expression, which then can lead to multiple changes, including the significant impact on the synapse between that peripheral nerve as well as the neurons in the dorsal horn of the spinal cord.
Thanks for that explanation. So, I mean, I guess one of the things that comes up as you're just describing that, I think we can all visualize or understand how, say, whatever, somebody with chronic ankle pain, you can upregulate the receptors in that area and continue to have pain, and so the receptors themselves are firing easier at first, and then they upregulate the receptors, and you have this chronic ankle pain. But how do you start? Or let me change the question. Can you start having that where, as opposed to it being localized in the body, say for the ankle, or in this patient's case, for the pancreas, abdomen, to it being more widespread, where they're much less able to kind of differentiate, ankle pain versus hip pain, or abdominal pain versus back or leg pain.
Yeah, and that gets into more the central sensitization to a degree, gets it more into the central sensitization component of this. And so we know with central sensitization, there's similar processes going on in terms of the neurons responding to a wider range of stimuli, and furthermore having a more amplified response to those stimuli. So some of the basic principles are occurring there. There's definitely with central sensitization, again, talking about structural as well as functional changes that are occurring. So like I said, functional, just mentioning the increased receptive fields and the increased response. Structural, a loss of inhibitory interneurons in the central nervous system, as well as changes in the brain itself. I know that we've talked about in the past, the gray matter volume that we see in certain chronic pain states, it actually decreasing, and the research would suggest that that's actually due to the dendrites themselves changing. And but to get to your question in terms of the pain becoming more diffuse, so a couple of things that we see with that. So when we do functional MRI studies on patients like, for example, with complex regional pain syndrome, you start to see that the areas of the brain that are processing that pain start to expand, and they're no longer localized to where they typically would be in a normal healthy state in the sensory cortex. But like I said, it becomes more diffuse and expanded. And then on top of that, another critical component of that is the wide dynamic range neurons in the dorsal horn, because those what we know about those wide dynamic range neurons is that they interact with cephalad and caudal segments in the spinal cord. And so that is when we think about the pain areas expanding and the crosstalk between different levels, I think that plays a key role as well, as those wide dynamic range neurons start to become functioning abnormally and become part of the central sensitization process that is occurring. That's when it becomes really difficult, because then, like you brought up, the pain's becoming more diffuse, harder to localize, and if you get pain at different levels, now because of that interplay between different spinal segments, when the pain signal comes into that spinal segment, it's going to be amplified as well.
So that kind of leads us back to our patient, right? So he, like I said, relatively young man that has been dealing with chronic abdominal pain from chronic pancreatitis for a very long time, on chronic opiates. If we kind of walk through some of the things that you had brought up, and so at that level of the abdominal innervation, or the abdominal receptors, he's been having this signaling of pain coming in over and over and over again, and so obviously thinking about, okay, receptors probably starting to fire a little bit easier. They're starting to get acclimated to that pain, upregulation of the number of receptors. Then you add in some of the central sensitization that you just described. Seems reasonable that thinking about the level of input for the abdomen and for the back relatively close together, that now some of that ambiguity can probably justify kind of what we're seeing clinically from him.
Yeah, no, I think that's a great point, because like you mentioned, so when we think about chronic pancreatitis, I'm sure some of you kind of thought about, okay, well, did this patient ever undergo a celiac plexus block? As we know, that's either ultrasound or CT guided, ultrasound endoscopic, or CT guided being some of the options there. But if you also think about, I remember, and I apologize, I don't have it in front of me, but there is a recent trial comparing T11 splanchnic nerve blocks versus celiac plexus block. But thinking about the level, then lower thoracic, that probably is being significantly sensitized in this patient. Obviously, with them having kind of thoracolumbar low back pain, as Dr. Hove has brought up, that's going to start to make sense of why it may start to be so difficult to treat that specific individual.
Yeah, and so maybe we don't have to be very specific for this case, but maybe we can take it a little bit more broad now. And so obviously, we haven't hidden our love of trying to help patients with challenges of chronic opioid use, with some level of sensitization to it, or patients dealing with chronic pain. Obviously, we've covered things like buprenorphine multiple times, as well as many other medications that work on the various receptors that are involved in all of these pathways. If you're thinking about a patient that's on, let's throw, say for example 300 400 morphine equivalents, they've been on that for 20 years, that with a fairly similar presentation to this, what are the things that start going through your head as far as understanding where they are? They're coming to you now with an acute pain flare of something that's not their primary complaint for the past 15 to 20 years. But obviously understanding all of this backstory and all of the sensitization to that, how do you start kind of digesting that and thinking about what your plans will be for trying to help this patient get to a better place?
Yeah, it's an excellent question, and probably one of the most difficult questions, or one of the more difficult questions, I think, in terms of the chronic pain management, interventional pain management. Again, I think the patient you brought up in the beginning is an excellent example, and we have tons of excellent examples. And sorry, this patient last night is just fresh in my mind because the exact same situation, right? Someone who has severe chronic pain, been on high doses of oxycodone, and has acute worsening of their symptoms, calling our clinic, requesting more medications. But they're on such high doses, kind of pushing for early refills. And so essentially the conversation I had, and I guess that's how I'll answer your question is, in these scenarios, and obviously there's so many different things you think about treatment wise, but just kind of focusing on the medication component of it, because, this is taking into account the fact that, sure, we've already, with these type of patients, we've already tried to wean them, because I think that's one important thing. Whenever we talk about buprenorphine, sure, we appreciate the utility of buprenorphine, but ideally we would taper that patient off of opioids and be using non-opioid medications. So we use buprenorphine when we feel like it's medically indicated and appropriate, and we feel like it's the healthier, safer option, for the patient. But sorry, to get back, like I said, more specifically to the question you asked, and like I said, kind of the conversation I had with the patient I was dealing with yesterday as well, is that, look, you're on very high doses of this medication. The most important thing right now is to continue to optimize our understanding and our diagnosis of what is going on with you, because clearly the treatments that we're utilizing right now, the risks are outweighing the benefits. And one of the concerns, and potentially one of the reasons we're having difficulty making these diagnoses and really truly getting to the bottom of what's going on and also treating it successfully, is that we have a state in the body where there's significant imbalance that, like we talked about, and the opioids are most likely only worsening that situation and not helping it. And so specifically from a medication standpoint, probably it is the best thing in terms of the patient's health, the patient's safety, and making any significant progress to transition them from that full mu opioid, which is probably on a spectrum contributing to some level of opioid-induced hyperalgesia and contributing to the sensitization of the neurologic system, and getting them onto buprenorphine, which we know from its unique pharmacologic profile, which, as we know, it's an agonist, a very potent binding but partial agonist to the mu-opioid receptor, an antagonist at the delta receptor, and an inverse agonist at the kappa receptor. Because of that unique pharmacologic profile, it actually has some anti-hyperalgesia qualities, and that's sorry, long-winded answer to get to that point. Is that, based on the animal model studies we have, based on what we see clinically with buprenorphine, by transitioning the patient to that medication, not only should it be just as effective, if not more effective, for their symptoms, but in addition, we could actually start to have a positive effect on some of that hyperalgesia that we're most likely significantly dealing with. And that's, again, probably one of the more difficult conversations to have with a patient because they're incredible pain. Their pain just worsened, and now you're talking about putting them on a medication uh, that they may have a different viewpoint of. So again, going back to last night, as soon as I brought up the word buprenorphine, the patient was like, "Well, isn't that a medication that's used for addicts? I'm not an opioid addict." And I know we've talked about this in the past, and you may have come across this with your patient that you were dealing with as well. But at that point, it's important to emphasize multiple things, including it's FDA approved for treatment of chronic pain. Obviously, Belbuca and Butrans being the formulations that are FDA approved. It's important to emphasize that there's research comparing full mu opioids to buprenorphine and demonstrating that buprenorphine is just as effective, if not more effective. So it's important to emphasize those things, and then it's important to emphasize to the patient that I'm using this medication to treat, this chronic pain state, and there's multiple reasons I'm choosing this. I talk about the hyperalgesia. The other really important things that I emphasize is that with with opioid medications in general, there's so much focus on the tolerance, dependence, addiction, and death, and of course we are we're vigilant for that, and that's incredibly important. But there's other long-term risks too. There's increased risk of stroke and heart attack. There's suppression of the immune system. There's causing and worsening depression. There's altering hormone levels. There's we talked about the spectrum of hyperalgesia and potentially pain signals that usually would be causing pain, causing more pain. So I emphasize to them those other long-term impacts of opioid medications, and then I bring up the fact that based upon the best available research we have, all those things I just mentioned, buprenorphine most likely causes those much less, if not at all. For example, with hormones, we know that there's minimal impact or immunosuppression, again, fairly minimal impact of buprenorphine on those things.
I think our listeners are really surprised because they thought they were going to get a case presentation, and you once again got an education on opiates and buprenorphine.
Yes, but I think it goes back to, and I apologize for that, but I think it goes back to, like I said, probably one of the most important things with the case you brought up, and one of the more difficult things too is yes, going back to the case, what do we want to accomplish? We want to continue to optimize the diagnosis of the patient's low back pain, figure out, is there, a specific target, especially from a procedure standpoint, but also we need to get them on the safest medication regimen possible. And I think, I know Dr. Karvelas has been working on getting the patient on buprenorphine, and that's kind of the rationale behind it.
Yeah, no, I'm sorry for my facetiousness, but I mean, that's, I think all of that, all of the case and lead up and, the education on the central and peripheral sensitization, it all is, those are the reasons why we have started, I shouldn't say started, the reason why we do believe in buprenorphine, right? This is the reason why have dedicated multiple podcasts to it to kind of help with the education about that medication and how to properly utilize it. Obviously there are multiple other medications that we find helpful. I mean, I think, some of the other things that come to mind, I mean, there's a lot of other medications, obviously, that can be adjuvant therapies to be able to help. And that, specifically for this patient, in addition to, like Dr. Karvelas brought up, optimizing the diagnosis, trying to utilize diagnostic procedures where appropriate to see if there are other things to be treated as far as anatomic pathologies that are contributing to the symptoms. But there are other medications that utilize various receptor pathways that can help out. I think, for myself, one of the things that we, obviously commonly do in pain management is, think about things like neuropathic agents, which sometimes, especially if it's a mostly GI problem or something that has been managed elsewhere, may not have been thought about, right? Utilize things such as muscle relaxants, which can either utilize, GABA pathways or the alpha adrenergic pathways to be able to be helpful in helping with some of this pain. Also, thinking about other tools, specifically in this case, clonidine is something that came up for this patient. And I know that you've talked about we've covered specifically Dr. Karvelas diving into some of the science behind thinking about things such as Namenda to be able to treat some of these more difficult cases. But these are patients that are there in the community, and these are patients that will present either to primary care or to pain management or somewhere random in between, that they're going to be there with an acute on chronic exacerbation. And the more that we can understand how to help them, how to educate them appropriately about what's going on, and to be able to implement a plan, devise first and then implement a plan and walk them through that implementation. Because Dr. Karvelas has brought this up many times. It's not easy. These patients are not easy, but generally speaking, with the appropriate education, with the appropriate understanding, A, that there is a plan, and B, what that plan is, and what it's going to be like going through it, I think we can be successful in helping these patients get to a better and safer place.
Yeah, definitely. And I guess just to wrap up, I know we've talked about before the transmission, um, modulation, perception, transduction, transmission, modulation, and perception pathway, and I think it's good to think back to that, because, like you brought up, these patients being difficult. These patients have been on a ton of different medication regimens typically by the time that we're seeing them. And the last thing we want is the patient to start to feel like we're just throwing, like, oh, well, have you tried gabapentin? Have you tried Lyrica? Have you tried Cymbalta? Have you tried topiramate? If they get that sense, then it's going to be problematic. And that's why usually with those patients, once we kind of emphasize the things that matter to us, optimizing the diagnosis, understanding that, hey, we know what you're going, or we understand the severity of what you're going through. Once we emphasize those things, saying we want to try this therapy because of this, and I think once the patient sees that, okay, there's a thought process and a reason behind this, okay, fine, we'll see what happens here. And I think there's it increases the likelihood of success to some degree.
Yeah.
But still incredibly difficult situation.
Hey, like I said, I mean, obviously I don't think this is. I shouldn't say that. The reason why we get all the training that we get is so that we can help the patients that nobody else can help, right? And I think even though it's challenging and it's frustrating, the success in these cases outweighs the success in so many of the cases that I think are a little bit more straightforward. And thankfully, I think we've both seen a lot of success in being able to help patients through this journey. And so I don't know where I was going with that, but
no, it's a good. I think it's a good way to wrap up, and that's kind of what I tell these patients, especially obviously every patient we see, but especially these patients, is we'll keep trying. There's, especially when you're dealing with these chronic, severe refractory pain cases, they are difficult to treat. They're difficult to make progress, at times. But the one thing that that we do promise to the patients is that we will keep trying until we do improve their symptoms as much as we can, get them as healthy as possible. That's ultimately all that matters. And the beautiful thing about this field of interventional pain medicine is that we do have so many options and so many different things that we can try.
Yeah. Well said, sir. Well, if you guys made it this far, thanks for allowing us to take you on a journey through a lot of different emotions in this conversation. We appreciate you listening. Shoot us a message on your favorite social media platform. Give us some feedback. Let us know if you like this format. I think this is the first time that we actually did this type of a presentation. So would appreciate if people actually enjoyed it or not. Please, if you hated it, just say, Dr. Joves, you're an idiot. Stop talking. But otherwise, we appreciate you guys, and stay tuned for those legal disclaimers.